home and abroad. I am Dr. Mohib, and with me, Dr. Malik Masumbillah. Together, we welcome all of you to the second day of First Bangladesh Congress on Epidemiology and Public Health 2021. This event is jointly organized by the Field Epidemiology Training Program Bangladesh, FETPB, and Epidemiological Association of Bangladesh, EPUB. We will start the day with a plenary session where two distinguished public health experts will participate. Dr. Kip Baggett serves as Chief of the US CDC's Workforce and Institute Development Branch, which includes the agency's support for Field Epidemiology Training Program and National Public Health Institute Development. From 2014 to 2016, he served as the Field Epidemiology Training Program Resident Advisor in Zambia, where he helped the Ministry of Health to launch this new program. Now, I am requesting Dr. Henry Kip Baggett to present us an overview and visionary of US CDC's Field Epidemiology Training Program.
Okay, great. Well, thank you very much for the opportunity to present to you today. I do really appreciate it. It's an honor to be invited to present at this first ever Bangladesh conference on epidemiology and public health. I know you've had quite distinguished guests at this meeting yesterday and then today, so I want to acknowledge the presence of the senior leadership in the room. I'm sorry that I can't be there in person and see who's actually there, but I very much recognize the importance of this event and really appreciate being involved in it. So thank you for inviting me. I'm going to go ahead and jump right in. It's okay. Can I just do a quick audio check? Can you hear me okay?
We can hear you. You can hear you. You can continue. You can continue.
Great. Okay. Well, thanks. And I'm going to be talking about field epidemiology training programs today, really from a global perspective. And I want to start not really with a typical background type slide, but what I want to talk about is impact. I want to start right at the beginning with talking about how FETP, field epidemiology training programs around the world, have had an impact on the global COVID-19 pandemic response. This is the biggest public health event of our lifetimes, almost certainly, and FETP has been on the front lines, as it has been on many big public health events over the past years. What I'm showing you here is a graph showing the results of a survey that we conducted of FETP programs around the world. And we we surveyed programs for their FETP contributions to COVID-19 preparedness and response. And the survey was built around WHO's 8 pillars of COVID-19 preparedness and response. So let me orient you to the graph here with the lines with the red circle. You see the blue bars here represent program contributions of FETP graduates. So for example, on the far left, you see country-level coordination for the COVID-19 response. 97% of the responding programs reported that their FETP graduates played important roles in country-level coordination for their COVID-19 response. The gray bars show the percentage of programs with trainees being involved in that particular pillar. So for country-level coordination, 60% of trainees. And you can see the high levels of participation across the 8 pillars. Now, looking at the dark blue bars, we see the percentage of programs with either trainees or graduates supporting the COVID-19 response in those countries. So the bottom line here is that FETP has formed a critical component of the public health workforce in responding to this global public health emergency. No surprise to most of you in the room, but it's nice to see data. So now I will take a step back and just talk a little bit about field epidemiology training programs in general. I know this is a review for some of you, but I wanted to be sure we're all on the same page. FETPs are on-the-job, competency-based training and service programs with a huge emphasis on learning by doing. So these are 2 points that I really want to emphasize here. FETP is unique in these ways. First of all, that the training and competency development happens by mentored field work, so learning by doing. Only 25% of the training is really based in the classroom to provide that didactic foundation, but the bulk of the learning happens in the field under supervision of experienced mentors. The other thing I really want to emphasize is the service component. FETP is a service program, meaning that the trainees are not just developing these skills for the sole purpose of building their own competencies, but rather they are providing a service to ministries of health, working on priority public health programs. So if you look at the graphic on the slide, I just want to make a point. CDC has been supporting countries to develop FETPs for over 40 years now. For most of that time, our focus has been on developing advanced level or 2-year programs, which you see at the top of that pyramid. These are very in-depth training programs to build very solid foundations in field epidemiology. We realized over the past 10 to 15 years that we were missing an important part of the public health system, and there were real gaps in field epidemiology competency needs at the district and regional level, and that led to the development of programs that were shorter in duration and really focused at different levels of the public health system, the district level and more the intermediate or provincial level in most countries. I'm going to say a little bit more about the differences in these programs here. I won't go through all of the details on this slide, but I do want to make 3 important points about the distinction between these 3 tiers of training, the frontline, intermediate, and advanced. First of all is the duration of training. The advanced program, as I mentioned, is a 2-year program. So participants in these programs typically leave their work position, so they take 2 years of study leave to work full-time in an assignment somewhere else in the Ministry of Health to complete the training. Contrast this with intermediate and frontline, which are usually 9 months and 3 months in duration, respectively. The next thing I want to emphasize, the distinction, is the full-time versus part-time. The advanced program is really a full-time program, again, where people leave their positions on a study leave, often relocate to a different part of the country, often the capital, where they participate in the training and are assigned to another position temporarily in the Ministry of Health. Whereas the intermediate and frontline programs are in-service programs. So the training takes place while people are still in their positions. These are still, the intermediate and frontline programs still adhere to the core FETP training model, where the emphasis is on that mentored field experience, but they're shorter in duration and the field work happens at their current position. This graph tells us a little bit about the growth of FETPs over the last 40 years. Specifically, what we're looking at is programs with which CDC has been engaged, either providing technical or financial assistance. And you can see that there has been steady growth since 1975, with a really rapid increase in growth starting in the early 2000s that corresponds to the expansion of the FETP frontline and FETP intermediate, which have really been the biggest growth areas for FETP over time. This slide shows a similar trend in the growth of the cumulative number of individuals trained in FETP. So looking back to 2014, we see that the growth in graduates from FETP and intermediate, or at least the growth in those 2 tiers, has exceeded the growth in the advanced program, which makes sense. We find that frontline and intermediate are to scale and easier to sustain because they're not as long in duration. Now, despite the many successes of FETP over the last 40 years, it has not been without its challenges. This slide lists a few of those long-standing persistent challenges that really have been there or been recognized since early on. I mean, if you look back at some of the early literature describing FETP, you'll see some of these same challenges being described, and I'm sure some of these will resonate with your program there in Bangladesh. The first of these is program institutionalization within the Ministry of Health or National Public Health Institute. So what we mean by this is really integrating the program into the government agency that's going to be running the program. So true organizational integration, technical and administrative oversight, as well as having stable financing. And this is understandably a challenge in many countries that we are often faced with. The next thing here is challenges for career paths for FETP graduates. And this stems from the fact that many countries do not have a position called epidemiologist or field epidemiologist in their human resources system. And so there needs to be a lot of work that happens between the program itself and the HR office to develop these positions. And it's often a long process, but an important one to be sure that the skills and competencies of FETP graduates are recognized in the system. The final challenge I have listed here is really a set of related challenges that stems from inconsistent resources for FETPs from a global perspective. The limited funding over time that we've had for FETPs is usually required to focus on program development in individual countries, which leaves very little for some of the important cross-cutting work that leads to innovation and network strengthening. Things like scientific conferences where FETP trainees and graduates can share their work and exchange ideas. Processes of accreditation to ensure the quality of FETPs. And then innovations in curriculum and curriculum delivery like e-learning platforms. These are things that have been long-standing challenges for us and for really the entire FETP community. Some of these challenges are what led to a group of senior leaders in FETP and global public health getting together and deciding that they wanted to do something about these challenges. They wanted to develop some recommendations and a process to try to address them because they have been such long-standing refractory FETP. This slide talks about the Global Field Epidemiology Roadmap, which was the main output of the group that got together to discuss these challenges. And this roadmap can be found on the TEFINET website. The Global Field Epidemiology Roadmap laid out 8 important recommendations for FETP going forward. And I won't go through all of these, but you will notice that most of them address those challenges or designed to address those challenges I mentioned on the previous slide. For example, looking at the first recommendation here, expand and modernize FETP core competencies and curricula. That speaks to the need to continue to evolve and evaluate the FETP curriculum to be sure we're meeting the needs of the modern field epidemiologist. You will also see a recommendation in here related to fully institutionalizing FETPs into country health systems. And then I do want to draw your attention to the very last recommendation here, establish a broadly representative strategic leadership group. That final recommendation may be the most important one because it really is about identifying a group of leaders who are going to be accountable for these recommendations, and that the Global Field Epidemiology Roadmap doesn't become a document that just lives on a shelf. This strategic leadership group has been assembled now. There are 14 members, co-led by Dr. Rebecca Martin of the CDC, the director of the Center for Global Health, and from Dr. Sose Fall, who is an associate deputy director at the WHO Health Emergencies Program. So the 14 members of this group have been assembled and will hold their first meeting, in fact, 2 weeks from today. So we're very much looking forward to those discussions and further recommendations. The Global Field Epidemiology Roadmap also developed a vision for FETP. And this vision is that every country in the world has the applied epidemiology capacities needed to protect and promote the health of its own population and to collaborate with others to promote global health and health security. The last part I added for our CDC orientation, the health security component. But this vision really speaks to what FETP is about. And I want to give just a couple of examples of why we think it is so important for every country to have these capacities. I started this presentation talking about the FETP's contribution to the global pandemic response. I think that is certainly the most timely example, but there are a couple of examples, other examples that I'd like to highlight. And one of those is a few years old now, but I think still really important and really rings true. And this goes back to the Ebola outbreak in West Africa from 2014 to 2016. And you will recall that that outbreak affected multiple countries, really 4 countries, sickened 28,000 people and killed 11,000. It was tragic. The devastation that occurred in Liberia, Sierra Leone, and Guinea was monumental. The outbreak also affected Nigeria. Nigeria had an advantage. They had an FETP in place since 2008. So they had FETP graduates and FETP trainees that immediately formed their response workforce. Nigeria, I also recognize, had some additional capacities that had been built through investments by partners over time. But the FETP's contributions were absolutely critical and essential. And in the end, helped to ensure that the outbreak did not spread into large parts of Nigeria, including Lagos, the biggest city in Africa, where it's very likely that the outbreak could have spread from there around to other cities in Africa and around the world. FETP was critical to making this happen. The next example I want to give relates specifically to FETP Frontline, because I really think this is a very important program and a very impactful program. And as I said early on, this is a program that focuses at the district level or local level, where surveillance data are first collected and aggregated and reviewed. And that is the focus of Frontline, is strengthening surveillance. And in this example here, in this table, what you see is a list of all the districts in the country of Benin. And for each country, we see the percentage of facilities in that district with on-time surveillance reporting. And in week 25, 1 week before the start of FETP Frontline, the average on-time reporting across these districts was 37%. Then we see the start of Frontline, including the first Frontline field work through week 32. Already we see the average on-time reporting increase to 79%. And by the end of the training, the 3-month training, the on-time reporting was 89%. So really a demonstrable impact on disease surveillance reporting from Frontline. This kind of impact of FETP was well recognized when the Global Health Security Agenda was developed. And I think most people are familiar with Global Health Security Agenda. But I just want to highlight here this particular target and particular technical area of workforce development, because it particularly calls out FETP and notes a 5-year target of at least having 1 trained field epidemiologist per 200,000. So this was a target that was laid out and recognizing the importance of having these types of targets. Following closely from that is the International Health Regulations Monitoring and Evaluation Framework. That target of 1 per 200,000 trained field epidemiologists was also captured in the Joint External Evaluation, which is a key part of the IHR Monitoring and Evaluation Framework. You will see in the workforce development technical area, one of the indicators or this target is specifically spelled out. So the idea of having trained field epidemiologists in countries at a target of 1 per 200,000 is codified in the IHR and its monitoring and evaluation framework. Now, having said that, we all recognize that achieving this target is no small feat, especially for a country the size of Bangladesh. And so I wanted to take just a couple of minutes today to talk about a couple of other countries that we work with that are also large countries and have faced challenges in meeting that trained field epidemiology target. Let me start with Nigeria with a population of 200 million. That means that they need to have approximately 1,000 trained field epidemiologists. Well, when their program started in 2008, they were training about 13 residents per cohort. And this is an advanced program, so a 2-year program. So you can quickly do the math and see how long that would take for them to reach this target of 1,000 field epidemiologists. Recognizing this challenge and in an effort to accelerate the training, in 2011, they expanded their training cohort to around 40. That same year, the Nigeria Center for Disease Control was established and provided real leadership to push this target and as part of their efforts to enhance preparedness and response. And as a result, their training cohorts have increased to a size of almost 60 per cohort. Now, another really important step that Nigeria has taken, is taking now, is starting the intermediate FETP program, which I described earlier. One important thing about the intermediate program is because of the depth of the training, we do consider that graduates of FETP intermediate to meet the criteria for being a trained field epidemiologist. This is not necessarily true of FETP frontline, where the focus is really on strengthening the skills of surveillance officers to improve surveillance. Still frontline, very important. But in terms of counting trained field epidemiologists, we look to graduates of the intermediate and advanced program. So by establishing intermediate, Nigeria is establishing a program that can train more people faster. The next country I'll mention briefly is China, with a population of around 1.4 billion, meaning they would need 7,000 trained field epidemiologists. And here, a couple things worth noting. Not only were they not training enough people, they also noted a real disparity in where the graduates of FETP Advanced were living and working. And you can see the dark blue parts of the map represent where the FETP graduates were residing and working. And so they were concentrated in the eastern provinces, the wealthier part of the country. China conducted an evaluation to really understand to expanding FETP Advanced and to the maldistribution of FETP residents, and that led to a couple of important changes. One of these was the establishment of an FETP intermediate program really focused on the western part of the country where the biggest gaps were. And that's one of the really nice things about intermediate, is because it is an in-service training, they could intentionally target staff who were working in these western provinces, because they do the training while they continue their jobs. The second thing they did was to support the establishment of intermediate programs at the provincial level. So many of the provinces have established their own FETP intermediate programs as ways to accelerate reaching this target of trained field epidemiologists. So just for those last couple slides, I want to summarize a few take-home points related to meeting field epidemiology targets in large countries like Bangladesh. First, FETP Intermediate can really accelerate the training of field epidemiologists and help address gaps in high-need areas. It's a shorter program, typically 9 months in duration, sometimes up to 12 months. The in-service nature of the training helps to target the training to geographic areas where the need is greatest, and also helps to ensure that those people remain in those areas because they don't leave their jobs. The second thing I want to highlight is the importance of data to inform the decision-making and to garner the political will to make changes where needed. And this is what China did with collecting data. Even things as simple as using a map that really shows policymakers and leaders where the needs are was very influential in this case. And also just conducting that evaluation gave them data to guide their decisions about how to address the gaps. And then finally, I can't overstate the importance of Ministry of Health leadership, ideally through a National Public Health Institute, as being very critical to making and sustaining progress in these areas. So that's my last slide. I'm going to stop there. I don't know if we're taking questions today, but if we have time, I'd be happy to take them. Otherwise, I thank you again for the opportunity to share this with you today.
বলে দিচ্ছি।
This is Mushtaq from Bangladesh. Many thanks for a good insight into the achievement of FETP around the world. I think in this Congress, Bangladesh experience will also be presented. Have you analyzed the data among the FETP trainees? Not only human health experts are there, experts from animal health and other disciplines are also being trained as FETP graduate, both at advanced, intermediate or frontline. Have you any analysis that what are they doing, those who are from the sectors other than health? Thank you.
Thank you for that question, and it's really important. We often put a big emphasis on One Health and efforts to emphasize the importance of collaboration across sectors. And I truly believe that one of the most effective ways to help promote a One Health approach to public health and surveillance and response is FETP by training staff from different sectors together, whether it's frontline, intermediate, or advanced, training government staff from both the animal health sector and human health sector together so that they're hearing the same language, they're training together, they're building networks and relationships. You asked if we had data on this. There actually is a manuscript that was recently accepted for publication that looked looked specifically at veterinarians and paravets participating in FETP. And it is, I think the conclusions of that were there are some really good examples of successes, but there are more opportunities to encourage this kind of co-training and collaboration. And I don't think it's in print yet. I'd be happy to work with Dr. Friedman to share with you what we have.
Thanks, Dr. Baggett, for your wonderful presentation. Our next distinguished guest, Dr. Michael S. Friedman. He is the CDC Country Director for Bangladesh since August 2017 and a U.S. Public Health Officer for 25 years. Dr. Michael will tell us about the importance of the public health workforce and how their role differs from the clinical workforce. Dr. Michael, microphone is yours.
While we're getting the slides set up, let me begin first of all, by thanking Dr. Kip Baggett for her presentation. It was very useful to get an overview of the FETP situation. And I think the situation that we see in Nigeria, for example, or even in China, very similar to the situation in Bangladesh now in terms of the size of our training of epidemiologists and our need to expand to meet the needs of the country. Here in Bangladesh, we need about 850 epidemiologists to meet the goal of 1 per 200,000. And currently, we are only producing 7 in the FETP program. So we do need to kind of think about scaling up the program and innovative ways to try to scale it up. My talk today, as we're getting the slides together, very briefly, is going to talk about what is a public health workforce. Okay, so we create epidemiologists. What are they supposed to do every day in the field? What is their job responsibility? How will it help the health system? Some of you may say, well, it's obvious. They'll help with outbreaks and they'll go out in the field and collect data. But I think we need to really think about this from a systems perspective. What is going to be their responsibilities, and how do they different than the current administrative staff that already exist in Bangladesh? We already have civil surgeons. We already have UHFPOs. So how would public health workforce differ from those positions? So I have my slide. So let's go to the third slide. Okay, next slide, please. So we can see here on this slide that a public health workforce does many things. One, it prevents epidemics and the spread of disease. It can protect against environmental hazards, promotes and encourages healthy behaviors, responds to disasters, and other factors as well. Focus on these type of, are they more dealing with administrative issues of how many people are at work in the different health centers? Are the medications showing up? Are the immunizations, vaccines?
Hello, Dr. Michael, we can't hear you. Please unmute your microphone, or there is an internet issue.
Can we have the next slide, please? Thank you. Okay. So this is some examples of the health work that could be done with the right public health workforce. Okay. For diarrhea disease, we need to focus on access to clean water, proper sanitation, and soap. We need to work with WASA and other entities within the government to ensure that the water supplies are kept clean. We often investigate at the end of it that it's because the water pipes, or that the water pipes are running too close to the sewer pipes. So these are the kind of preventative steps that need to be taken, as an example. HIV, we know around the world, there's a lot of prevention work. Malaria, again, focus on bed nets, environmental control. For malnutrition, there's a number of things that can be done around micronutrients, food security, and cultural practices, including breastfeeding. Anemia, we focus again on cultural practices, iron supplementation, and family planning, which has been a very successful program here. There's a tremendous amount of focus on changing the social norm, establishing services in non-clinical community settings, which Family planning is a very good example of a public health approach that's been successful in Bangladesh. Next slide. Tobacco is another great example where there's a tremendous amount of focus around the world focused on changing tobacco control. Doctors and clinics have a very low likelihood of changing people's behaviors in terms of tobacco use. But if we have things like cigarette taxes, banning advertising to minors, anti-smoking campaigns, and other efforts, these have been shown around the world to dramatically reduce tobacco use. Road injuries, there's a number of things that can be done here. It's a huge issue in Bangladesh. Obesity, focusing on the built environment, the food industry practices, community nutrition and exercise. And asthma, of course, we have a huge problem in Bangladesh with outdoor air quality as well as indoor air quality. And these contribute not just to asthma, but also to heart disease and cancer risk as well. Huge cause of premature mortality in Bangladesh. And finally, diabetes, which is an emerging health problem. How can we deal with diabetes, not from a clinical standpoint, but from a community level in terms of improving diet and exercise programs? So these are all examples of how a public health workforce would tackle emerging and very important health issues. And this list is not obviously other health issues out there as well. Next slide. Go ahead, the next slide here. Keep on going, the next one. Sorry. Yes. So you can see here, when we think about public health, at least in the U.S., defined it as these items here on this list. And I won't go through them individually, but you can see here that these are very different than what a clinical workforce would do. Next slide. This is another way of looking at that same list, slightly different, but in a similar idea, which is that the public health workforce will assess community risks and community issues. They help develop policies and community actions. And then they also provide assurance that these actions are actually being taken and that behaviors and regulations are actually changing. So this is a very different way of thinking about your job, very different than what we learn in medical school in terms of how you address a problem. Next slide. So this is another way of thinking about it. This is basically thinking, okay, if I have a staff that's supposed to deal with public health issues, how would it be organized? This is just one model which has public health leaders. These are program managers, epidemiologists, policymakers, and advocates at the center. And they have a team of sanitarians, environmental engineers, community mobilizers, and behavior change agents. They work with the media, the youth, and community-based organizations, outreach staff, and community clinic staff, and community nutrition monitors. This would be an example of how a public health system could be developed and organized. Next slide. So how does this work globally in terms of most health systems? So it's a little bit complicated, and then every country is a little bit different, but there are basically 4 different models here of how a health system is organized when it comes to public health work. One is that public health, model A, is the public health and the clinical workforce is completely separated at the national, state, and local level. So the people that are doing public health are completely different than the clinical workforce. The second model is that there's some separation of public health and clinical function at the national, state level, but at the local level, it's very integrated because some of the same staff have to do both services at the local level. Model C is that there's a full integration at all levels of the system. So people are responsible health system is basically ignored. So you don't have a public health system. You just have a clinical health system. Now, it's a little bit challenging to know which model Bangladesh is in. Some would argue that we're in model D, but some would say that's not true. We do have some key public health functions that are strong in Bangladesh, such as family planning and immunizations, as an example. And we may say that in that case, it's really model C, because these programs, family planning and immunizations, are integrated throughout the entire health system. So, and then some would say that no, there's some differences at the national level, but that really we have more of a model B system in Bangladesh, where there's some separation at the national level, but it's integrated at the local level. So we, depending on the health issue and the public health issue, we could say we have different models working in Bangladesh. But
Thank you, Dr. Michael. It's our great pleasure to hear both of you in the plenary session of the first Bangladesh Congress on Epidemiology and Public Health 2021. Thanks to both of you.